rheumatic fever causes mitral stenosis. And before that, we showed you how acute rheumatic fever causes acute mitral regurgitation. Well, what if I told you we're not done with mitral regurg just yet, huh? What if I told you there are actually a bajillion different things that can cause mitral regurg? Well, just close your eyes, hang on tight, clench your gluteus, and take the plunge as we illustrate the what, why, when, where, and how, and quite possibly the whence and wherefore of both mitral regurgitation and a related condition called mitral valve prolapse. Welcome to the Jester Jump Club. Believe me, my friend, once you feel the chafe of a rudimentary fashion medieval motley jester suit whilst falling at terminal velocity, you'll never skydive any other way. Aw, look, this guy's a little nervous about his first jump. Come here, you. He's what we call a junior jester. We'll take it slow, don't worry. That jester hat is a recurring sketchy symbol for a floppy and incompetent mitral valve. See those two sagging bicuspid points? And as our newbie here nervously regurgitates all over himself, I want you to imagine systolic contraction sending blood shooting backwards through that mitral valve. Hey, did I tell you we also do parasailing? When you look at that parachute, I want you to imagine the two leaflets of the mitral valve billowing back up into that left atrium. This is called mitral valve prolapse, and it's the #1 cause of eventual mitral regurgitation, which is when blood actually starts shooting back through. So why do the leaflets like to parachute upwards like that? Well, it's usually due to a disease called myxomatous degeneration. And in this scene, when you think of myxomatous, think of a mixer, like the one propelling that parasailer forward, defying all laws of physics. Myxomatous degeneration is just a special name for the pathologic deterioration of the connective tissue that holds the valve together. So if you look closely, you'll notice that our myxomatous mixer is starting to get tangled in the connective bands there. That won't last long. You'll sometimes hear other terms thrown in there, like redundant mitral leaflets and elongated chordae tendineae, and that the fibrosa is thin and the spongiosa is thickened. But just remember that we're deteriorating connective tissue here. Myxomatous degeneration is a chronic disorder, but the mitral valve can prolapse right back up into that atrium acutely as well. This occurs during chordae tendineae or papillary muscle rupture, when the chordae that hold the leaflets are let loose, leading to acute mitral prolapse and regurg. We've seen this happen before, during a right-sided MI, for example. At Sketchy, myocardial infarction is always represented by a ruptured heartstring. Recall that the posteromedial papillary muscle is usually fed by the right-sided coronary circulation. Cut off its blood supply with a thrombus in the right coronary, and that ischemic papillary muscle may just rupture. Remember when I said that myxomatous degeneration is a chronic disease? Well, when it affects the chordae, the connective tissue can get stretched and weak, and sometimes it acutely ruptures. Honestly, that thing really shouldn't be flying anyways. Another important cause of chordae rupture is infective endocarditis. At Sketchy, myocarditis, or inflammation of the myocardium, is represented by a heart on fire. Endocarditis, on the other hand, which involves inflammation of the innermost endocardium, is depicted as a fire coming from within the heart. So we usually use a heart-shaped lantern, like the one this guy is using to signal for help. As we'll illustrate in our infectious disease unit, infective endocarditis involves bacterial infiltration of the endocardium, and that means the valves are involved as well. If enough damage is done to that mitral valve, the chordae can acutely rupture, leading to acute mitral regurg. Okay, so in the left corner of the sketch, we've illustrated a few reasons why that mitral valve will acutely start sending blood in the wrong direction. Hyperacutely, in fact, due to immediate rupture of supporting structures. It's not hard to imagine that the heart does not have much time to respond. Let's look at the hemodynamic consequences. First, imagine the left ventricle pumping underneath that acutely ruptured mitral valve. Instead of blood heading out through the aorta, a ton now shoots backwards toward the left atrium. Say goodbye to cardiac output. It's kind of like the low output on this cardiac flashlight here. So, since blood is shooting backwards instead of out to the circulation, it accumulates in the left side of the heart. And when the ventricle fills again during diastole, it now has to accommodate the regurgitant blood volume along with the normal pulmonary venous return. In other words, there's an acute increase in end diastolic volume. That means an acute increase in preload. Preload, remember, is the volume that the heart has to move with each contraction. At Sketchy, preload is represented by load getting pulled, as depicted by this concerned jester here, pulling on his unconscious friend who has just suffered a major rupture. Retrograde flow causes increased pressure in the left atrium, which transmits all the way back to the pulmonary vein, causing pulmonary venous hypertension. This will manifest as flash pulmonary edema, depicted, as always, by a soaked pulmonary life vest. As the ventricle contracts, that regurgitant mitral valve now provides a new low-resistance path for blood to travel. This translates to a decreased afterload faced by the heart. If preload is the volume in the chamber that the heart has to move, afterload is what the heart has to push against in order to get its load out. So at Sketchy, we represent afterload with someone pushing against a load. And since afterload is acutely diminished, his load is sent cascading off the side of the canyon. This will actually cause an overall increase in ejection fraction. The ventricle has a larger volume to deal with, sure, but now it has 2 outflow tracts through which it can eject blood. So it's able to empty more of its contents. At Sketchy, increased ejection fraction is represented by a fraction lifted into the air. So you see the wedge shape cut into this heart hang glider? Kind of like the fraction of a pie graph? As he takes off into the air, imagine ejection fraction increasing. Whee! However, this does not mean increased cardiac output. Remember, a lot of that stroke volume is sent in the wrong direction, back toward the atrium, so cardiac output drops. If severe enough, this leads to the abrupt onset of cardiac failure, severe hypotension, and cardiogenic shock. At Sketchy, shock is represented by a lightning bolt, like the one labeling these batteries here. This is one of the feared outcomes in the first 10 days following a right-sided myocardial infarction, for example. That ischemic posteromedial papillary muscle might just rupture on you, causing complete cardiovascular collapse. Hey, where are you going? What? No, these are just some extreme examples of hyperacute mitral regurg. Because it happens so fast, the heart doesn't have time to respond. Don't worry, just put your jumpsuit back on. It'll be okay. Because most of the time, the regurg starts out small, or it develops more slowly before becoming clinically significant. That way, the heart is able to adapt. Let me show you what I mean. You remember mitral valve prolapse, right? That billowing parachute of a mitral valve caused by myxomatous degeneration? I mean, look how much fun that guy's having back there. Yes, the occasional rupture can occur, but in most cases, mitral regurg develops gradually, remaining asymptomatic for years. Rheumatic heart disease is another good one. Recall from our last sketch that acute rheumatic fever occurs because your own immune system tries to attack a group A strep infection, but attacks your body instead. This leads to acute rheumatic fever and all those acute Jones criteria symptoms, including valvulitis. Just from this one episode, the damage to the mitral valve can be permanent, and a slow, progressive mitral regurg develops over time. This is called chronic rheumatic heart disease. Stenosis is actually more common at this late stage, but regurg is often present as well. And yes, we're bringing back endocarditis, hence the return of our recurring heart lantern with that fiery inner surface. After crashing in the forest a few days ago, it looks like this motley fool has finally made it back to camp, accumulating some vegetation along the way. You see that sagging bicuspid hat, covered in debris? In the setting of infective endocarditis, bulky vegetations composed of bacteria, inflammatory cells, and fibrin develop on valve surfaces and cause direct destruction of the underlying valve architecture. The aortic and mitral valves are most commonly affected. The onset of mitral regurg can actually be quite sudden. And if this progresses to heart failure, the patient usually goes straight to surgery to get the valve repaired or replaced. Even after the infection passes, patients can be left with a chronically regurgitant mitral valve. Okay, each of the valvular disorders we've covered so far is an example of primary mitral regurg. In other words, the abnormality lies within the components of the valve apparatus itself, either the leaflets or chordae tendineae or annulus. Compare this to secondary mitral regurg, which is caused by abnormalities in the surrounding heart structures, not the valve. This is seen in left-sided heart failure, for example. Take a look. You see that floppy failing heart balloon? That's a recurring sketchy symbol for heart failure. And in volume-overloaded hearts specifically, the myocardium undergoes eccentric hypertrophy, leading to a big, dilated chamber. This stretches open that mitral valve annulus to cause regurg. A similar process occurs in the setting of dilated cardiomyopathy. Yup. Whether it's a sac race, bag of birdseed, or hot air balloon sandbag, dilated cardiomyopathy is always symbolized by a floppy heart bag. So again, let that basket remind you of the mitral valve annulus getting stretched open by the chambers that surround it. In these past few examples of primary and secondary valve disorders, mitral regurgitation often follows a course of chronic progression. This means that the left atrium has time to adapt. Take a look at the enlarged chamber of that hot air balloon that's in the middle of taking off. Our recurring chronic grandfather clock should remind you that this is chronic mitral regurg we're talking about here, and it causes the left atrium to dilate and undergo hypertrophy. As the atrium takes on more blood, less pressure is transmitted back to the pulmonary circuit. This is why chronic mitral regurg usually will not cause significant pulmonary edema. We've subtly highlighted a couple other hemodynamic principles here as well. First of all, when disease takes a chronic course, mitral regurgitation reaches what's called a compensated state. In other words, we have a preserved cardiac output. In the hyperacute setting, the heart had no time to react, and cardiac output plummeted. This time, the heart reaches an equilibrium that allows it to maintain forward stroke volume. So let that undying flame remind you that cardiac output is firing away and doing just fine. This requires a chronically increased ejection fraction, however. In order to maintain cardiac output, the ventricle has to eject an adequate amount of blood into the systemic circuit, even though a portion of that stroke volume is wasted through a regurgitant valve. An increased ejection fraction will make up the difference. And as always, we have a fraction raised up in the air. A fraction of pi, that is. In compensated mitral regurg, then, that left ventricle is dealing with chronically increased ejection duties and volume overload. That means chronically elevated preload in that chamber. And you know that means we need to draw someone pulling on a load. It's the sketchy way. So we've added a gesture here, pulling on that balloon, trying to keep it from taking off. This chronic volume overload, however, causes the left ventricle to undergo eccentric hypertrophy. This is when the myocytes grow lengthwise in series, causing the chamber to grow larger. This lengthwise addition of sarcomeres is depicted by that extended myocardial ribbon. Just like in our heart failure sketch, however, once eccentric hypertrophy sets in, there's no happy ending. Eventually, the heart just can't take it anymore. It's too much pressure and volume in the chamber to contend with. And as cardiac output falls, your patient with chronic mitral regurg will begin to manifest symptoms of heart failure. Well, that was a downer. How about I cheer you up by talking about a few fun heart sounds you'll find on physical exam? The murmur of mitral regurg is described as a blowing, hollow systolic murmur heard best over the cardiac apex with radiation to the axilla. And we've shown that here. We've got our usual systolic spray to denote a systolic murmur. And if clenching a gesture in your armpit doesn't remind you of radiation to the axilla, I don't know what will. We'll even add a subtle and totally 90s hologram sheen to that gesture jump club sign. That's holographic for hollow systolic, meaning the murmur is heard throughout systole. See what I mean? Dilation of the left ventricle, as we mentioned before, is a compensatory mechanism that helps maintain cardiac output. This leads to an S3 gallop as blood rushes into that dilated floppy ventricle. In fact, the most reliable auscultatory finding indicating severe mitral regurg is a prominent S3. It comes right after S2. You hear it? Since it's caused by blood sloshing into a floppy chamber, just remember the phrase, sloshing in, sloshing in, sloshing in. The holosystolic murmur of mitral regurg is actually less reliable for estimating the severity, as a wider regurgitant path causes a softer murmur. By the way, remember the mitral regurg caused by heart failure? It occurs when the mitral annulus is stretched open by volume overload. It makes sense then that if you fix the volume overload with diuretics, not only do their heart failure symptoms go away, their murmur goes away too. Less volume means a smaller chamber and a smaller mitral annulus. Therefore, no more regurg and no more murmur. Just think of this jovial jester here, diuresing all over himself with glee as he squeezes shut that mitral hat of his. Alright, let's wrap up the sketch with a quick discussion of the specific exam findings associated with mitral valve prolapse. Remember that one? It involves the mitral leaflets billowing up like a parachute into the left atrium. It's usually caused by myxomatous degeneration of the mitral valve, and it's the most common cause of chronic mitral regurgitation. Well, I first just want to mention that the same scenario can occur in a variety of connective tissue disorders, including Ehlers-Danlos, Marfan syndrome, and osteogenesis imperfecta. This Marfan here will embody all of these disorders. He's even donned the myxomatous mixer to remind you that you'll find the same basic pathology of myxomatous degeneration, which really just means some kind of connective tissue degeneration. Yeah, we do every kind of extreme sport here. Parasailing, hang gliding, blender. So why not ziplining? The posts are labeled S1 and S2 to remind you that the murmur associated with mitral valve prolapse can be heard during systole, in between the S1 and S2 heart sounds. Hear it? What you really need to listen for is that classic mid-systolic click. See that guy clipping himself onto the rope with his carabiner? Click. That click is caused by floppy stretch chordae snapping taut as the valves prolapse through the mitral annulus. A regurgitant murmur may also be present, so also listen for the typical holosystolic blowing murmur best heard over the apex and radiating to the axilla. Just like before, different maneuvers affecting preload and afterload can influence the intensity of the mitral prolapse murmur. Isn't that fun? Decreasing preload, for example, by Valsalva or by standing from a sitting position, will shorten the length of systole and cause a click to move closer to S1. That's why, close to the S1 post, we've got a nervous customer standing and maneuvering a Valsalva like none other. It's okay, dude. Just make like David Lee Roth and run with the devil. Right over to the other side. What? What did you think I was going to say? Anyways, anything that increases heart rate, like anxiety or exercise, will also have the same effect of moving that click closer to S1. This time it's because of a decreased diastolic filling time. See that elevated heart watch? That means tachycardia in our secret sketchy language. So we decreased preload. Now let's increase preload. Take a look at the picture-perfect landing technique on display here. You've got to raise those legs and then squat at the finish. A supine leg raise and squatting are both easy ways to increase venous return, increase preload, and prolong the length of systole. This moves the click closer to S2. Sustained hand grip can do the same thing, though this works by increasing afterload and slightly impeding left ventricular emptying, thus lengthening systole. Just remember that you'll have to prolong that hand grip if you're going to be able to zipline all the way to S2. All right, that about sums up the mitral valve. Let's see. We've covered rheumatic heart disease causing mitral stenosis, and now all this floppy mitral regurg gesture juice. It's time to put on our princess hats and head on over to the aortic valve.